I've had the great pleasure of working with Dr. Evangelista and many others on the IRAD registry, which we founded in 1995. It's remarkable that we're going to be coming up on 30 years working together in the next several years. And to kick off this part of the conference, I'm just going to talk about some of the key findings that we've had working together over the past 25 years. Next slide. These are my disclosures. The IRAD registry is wonderfully supported by a number of entities. So the comments that I offer today, for example, on stent graft therapy, you would have to understand that we've received funding from entities like Gore and Medtronic through the years, so that you'll have to filter my comments with that in mind. And the next slide. One of the things that we discovered in IRAD is that old classification system of an acute dissection being something that's within 14 days and a chronic dissection more than 14 days was way, way out of date. And if you look at the bottom part of this slide, the IRAD investigators believe that we should divide the time from onset of symptoms until patient presentation into 4 distinct categories. The hyperacute phase is that first 24 hours. And then acute, the next, say, 6 days from day 2 to 7. And then from day, say, 8 until 30, subacute, and then chronic after 30. And what you see in this slide is that non-operated type A dissection has a very steep mortality when not operated in the first 24 hours. There's additional attrition in the next 6 days, some further attrition until about day 30, and then the line flattens out. And we think this is a more proper classification system based on time for acute aortic dissection. Now, next slide. If you look at the demographics and past history of patients who have aortic dissection, we talk a lot about familial aortopathy and Marfan syndrome, and they're very important. But this slide, I simply want to illustrate the fact that nearly 20% of patients who have an aortic dissection have a history of prior heart surgery. And I think this is a somewhat underappreciated risk factor for dissection out there in the literature. And I wanted to highlight it for you today. Obviously, this could relate to a patient who had an aortic valve replacement, and in fact, they had maybe a bicuspid valve and later had a dissection from aortopathy. It could be a patient with a CABG, where the cross clamp and or the vein graft insertion creates a weakness in the aortic wall. There are a number of reasons why this association exists, but it's an important one, I think, for our audience today. Next slide. The symptoms of dissection are unique, and this is a quote from Paul Dudley White dating back to 1944, describing the typical pain of aortic dissection. And what he described is that the pain comes suddenly at its maximum. Most patients with an aortic dissection have a nearly photographic memory of exactly how and when the pain started and exactly where they were. And this distinguishes this entity often from other entities such as myocardial infarction, for example. Sudden, severe onset of pain. And remarkably, sometimes the pain goes away. And this can be falsely reassuring to the care team seeing a given patient. And the next slide, please, shows you the various pain features in acute dissection according to the IRAD registry. And that abrupt onset is the most sensitive of all the pain markers that we see in these patients. And of course, most patients have pain. Most of those who don't have pain have had a syncopal episode and or a stroke. So pain is nearly ubiquitous in patients with acute dissection, and sudden onset is the key historical clue that gives us a thought about this diagnosis. Now the next slide. One of the things that we discovered in IRAD, and others have subsequently discovered, is that aortic dissection is not necessarily going to occur in an aneurysmal aorta. In fact, some patients dissect in a normal-sized aorta or minimally enlarged. This is a study we published many years ago showing that, excuse me, that 60% of patients had an aorta that was smaller than 5.5 centimeters at the time they dissected. And you see on the left side of this bar graph that there were not a small fraction of patients that had aortas between 3.5 and 4, 4 to 4.5. So for years, we've sort of been thinking that dissection happens in an aneurysmal aorta. And that does occur, of course, but many of these patients have only mild enlargement or even sometimes no enlargement at all. Next slide. We're getting better and better with our diagnosis and treatment of aortic dissection. And these two bar graphs illustrate the improvement in outcomes over the 25 years that we've been studying aortic dissection in IRAD. And then that right bar graph, you see that the percentage of in-hospital mortality for type A dissection has fallen from nearly 30% 20 years ago to about 20% in the more recent era. And these data continue to show evidence that we're doing better with earlier diagnosis and better therapy. Also, you see on the left side that this bar graph shows that our cardiac surgeons are taking on more and more of the type A patients, whereas in the early 90s and early 2000s, a patient with 75 or 80 might be denied surgery because of consideration of their advanced age. Nowadays, we're seeing excellent results in patients that are well into their 70s and even their 80s. Next slide. And this is further illustrated by this data from the IRAD, which suggests that the current in-hospital mortality of operated type A dissection has fallen from nearly 18% when we started, to around 12%. And many hospitals, very likely yours and mine, now have operated mortalities that are in the 10% or even less range. This is certainly a victory for modern day surgical technique, anesthetic technique, cannulation technique, et cetera. Next slide. This graph, it may be difficult for you to see, but it basically illustrates the difference in mortality between medically managed type A dissection and surgically managed type A dissection over the lifetime of risk. And what it shows, I think, rather clearly is that at least up until the age of 80, and maybe even later, that the operative mortality for type A dissection is substantially better than medical treatment. And I think increasingly our surgeons are recognizing that. And so a patient who otherwise has reasonable operative risk other than advanced age increasingly is being offered an operation today. Now the next slide. This slide is illustrative of outcomes in patients with type B dissection with varying degrees of malperfusion. And what we did in this study is to look at the number of abnormal beds of malperfusion in a given type B patient and map that in terms of perioperative outcome or hospital outcome 30-day and 1 year. And you might expect, and it's true, that there's almost a linear correlation. The increased number of beds of malperfusion, increasing risk of mortality, whether it's the brain, the leg, the gut, et cetera. The more malperfusion we see, the more likely the patient is to expire. And this is, I think, illustrative in this particular analysis. And now the next slide. You know, we've been very interested in whether or not stent graft therapy offers benefit in patients with stable type B dissection. And this is a study that looked at patients with acute dissection in IRAD type B. And we asked the question, what was the outcome if they got a stent graft during their hospitalization? And this, of course, excluded patients who had clear indications for stent graft therapy. And what we saw that over the first couple of years, there did not appear to be a difference between the medical treatment of type B and those who got a stent graft. But after 2 years, we saw a gradual diversion of the curves, and there appeared to be some benefit from the stent graft therapy later on, out at 5 years. Of course, the notion of this is that the stent graft allows stoppage of remodeling of the aorta. The false channel does not expand, and there is less chance for rupture or further dissection in that circumstance. Clearly, we need randomized trials in order to answer this question, and there are now 3 of them that are underway, one in Scandinavia, one in the United Kingdom, and one led by Dr. Firas Musa, who you're going to hear from today, in the United States. So in the next 5 to 10 years, we'll have a definitive answer whether or not stent graft therapy for stable type B dissection should be something that we should consider on a more routine basis. And the next slide. Um, we've been searching for a biomarker for acute aortic dissection for a long time. And Dr. Toru Suzuki and others have been in this scientific area for 30 years. I'm glad to say that we do have a very sensitive biomarker for dissection, and that's the D-dimer. And this study that we did in IRAD showed that patients who present with acute chest pain, the D-dimer is massively elevated, you see on the left side here, in patients who present early with an aortic dissection. And frankly, it's much higher typically than a pulmonary embolus, or that can occur with a myocardial infarction where there's associated thrombus in the left ventricle. So we do have a very sensitive biomarker, that's D-dimer, for acute dissection. Admittedly, it's not specific, is it? We see patients with PEs and other conditions that have elevated D-dimer, but certainly this is very sensitive, probably in the range of 98%. Now we need a specific biomarker, one that only gets released by a tear in the media of the aortic wall, and a number of investigators are working on that, and hopefully we'll have a platform with both a sensitive marker, D-dimer, and a specific biomarker like a fibrillin fragment, for example, that will be useful in our emergency rooms in the future. Now the next slide. So I currently believe that D-dimer is very helpful in the evaluation of patients with chest pain. This is a wonderful algorithm that was shown to me by Arturo, thinking about the use of both D-dimer and troponins in patients who present with chest pain. And the D-dimer can be very, very helpful in teasing out a patient who does not have an MI, but rather has either a PE or an aortic dissection. Now the next slide. Increasingly we're learning things from imaging that are very important. And it's ironic, I recall being in the car with Arturo Evangelista maybe 20 years ago, talking about a patient that I'd been taking care of with a type B dissection, where we saw over time the false channel started to thrombose. And not long thereafter, the false channel began to expand and ultimately led to a catastrophic outcome. And Arturo described to me that he'd seen several patients like this as well. So we went back and looked at this in our IRAD database. And lo and behold, we found that patients who had a type B dissection, where they partially thrombosed the false channel, had a higher risk of poor outcomes. And our reasoning was that perhaps by sealing off those distal reentry channels, we were creating a blind loop up above, and that this led to increasing wall stress and expansion of the false channel. And this is just one example of how dynamic imaging over time can be more helpful to us than simply measuring things like the diameter of the aorta. And there are many, many areas of active interest in imaging that I think will be very helpful for providing more precision care to our patients. Next slide. We do a lot of intense care for patients who have a dissection, and then they get discharged. And what happens to them after they get discharged? We studied this in a group of IRAD patients, and what we found was quite sobering. The survivorship after successful dissection treatment is not nearly as good as we would like. This slide illustrates that about 40% of our patients are disabled from work. Almost 3/4 of our patients said they stopped having sexual relations entirely because they were afraid. Depression was very common. Anxiety was very common. And most of the patients described a sense of not knowing what they could do, how they could function, how normal could they be. So I think this is a huge frontier for us in the dissection world. We need to do a better job of defining proper survivorship. And that relates to nutrition, physical activity, et cetera, et cetera. Next slide. Similarly, if you ask dissection survivors what they really want to see happen in the future, 50% of them want education to doctors so that they know how to properly diagnose and treat dissection. A lot of them want to know what's the right answer for me in terms of genetic testing. What kind of exercise can I do? When I have a subacute dissection, should I have surgery? There's so many questions that patients have that we need to answer. We've done a great job of improving care of acute dissection, But I think we've ignored this frontier, which is after my dissection, okay, what now? How should I be treated? What is safe? What kind of activity can I do, et cetera? Next slide. You know, it's interesting. King George was the first, I think, first publication of dissection back in 1760. And, you know, watching this field over the last 35 years, I feel like we've discovered a lot. But in some ways, I feel like we're now just beginning. You know, the genetic story, the imaging story, the survivorship story, the biomarker story, all of those are frontiers right in front of us. And I'm excited for this next generation of scientists and caregivers to help chart a course for better patient care and outcomes. The next slide. I love this quote by Charcot. Disease is very old, nothing about us changed, but we change as we learn to recognize what was formerly imperceptible. And certainly this is a good example of, with aortic dissection, we need to get deeper into understanding genetics, imaging, survivorship, et cetera, to do better and better for our patients. Next slide. You know, there are 60 sites around the world that are currently working in IRAD, and this is their data, it's not my data. People like Arturo Evangelista and others that are at the conference, you know, working with you these, you know, almost 3 decades has been a great joy for me. And I look forward to the next 30 years as we continue to chart a course to understand this illness and treat it better. And the next slide is just a shout out to my collaborators at Michigan. I work in a wonderful aortic center here with absolutely fabulous faculty and nurses. And this also is their work, and I appreciate them very much. And then the last slide. You know, one thing we know for sure, if you've seen one dissection, you've seen one dissection. And every one of them feels different, doesn't it? It's a pleasure to be in the healthcare industry and fighting this really lethal condition. And I really appreciate the chance to talk to you today and contribute to this important course. Thank you very much.